and the Whittington. And I've also got a couple of my colleagues with me here today. I've got Emma Prescott, who's the thalassemia specialist nurse at the Whittington and has been working in this area for quite a few years. And then I've got Chris, who's CNS and joint education lead for our network, along with Bernadette, who is newer to the area, but also has a lot of experience, mainly from a paediatric perspective. Great stuff. So if people have questions, there'll be opportunities after. What we're going to do is give a bit of an introduction to the collator, and then there's going to be some cases, and we'll have a discussion around the cases after each case. So do feel free to, once the case is finished, when it's or appropriate points within the case when prompted, do please stick your hands up or put any questions or thoughts in the chat, and Bernadette and Stuart will keep an eye out for those. If you're not speaking, if you can mute, or if you're not asking a question, can you mute yourselves? And just so we don't get a load of background noise, etc. Okay, that's great. Brilliant. So can I make this go forward? There we are. So I've gone over that. So just very briefly about the thalassemia syndromes. So most of our centres don't have, thalassemia is sort of a, we have smaller numbers of thalassemia patients compared to our sickle cell patients. And although we always put them in together, they are different sort of from a pathophysiological basis. So whereas sickle cell is a qualitative problem, so there's plenty of hemoglobin, but it has the change in the gene that then changes the structure, that changes the charge, causing the polymerization and sickling of the red blood cells. With the thalassemia syndromes, it's actually a quantitative problem where you get a mutation in either the alpha or beta globin gene, and that leads to reduction in either alpha or beta globin chains. And so you then get an excess of the other ones. So in beta thalassemia major, for example, you get an excess of alpha chains, and those alpha chains actually damage the red blood cell precursors and can cause hemolysis of red blood cells in the peripheral circulation. And this destruction of the erythroid precursors in the bone marrow and extramedullary sites, and how the bone marrow responds to that, then i.e. trying to replace those cells, is called ineffective erythropoiesis, because it's working hard, but the output isn't what we want. So what we hope is that with transfusion chelation therapy, thalassemia patients can be expected to have an improved life expectancy, as you can see from this graph here, taken from Paul Telfer's cohort data. But we still do see problems secondary to iron overload. And the problem is that none of us, and certainly not my patients, are going to be 100% concordant 100% of the time. And although we don't see necessarily, like we used to, pediatric patients with massive cardiac iron overload, we definitely do see patients with significant cardiac iron overload for a number of reasons. Diabetes is increasingly common, and hypogonadism and hypothyroidism are still seen, particularly among our older patients, even those who have significantly de-ironed a long time ago because of historic damage, and then the impacts of aging. So what have we got? Chelators in clinical use. The oldest one is desferrioxamine. Classically, it used to be given back in the day IM, and some of my patients had a sort of special gun thing that used to fire the desferal into them, and unsurprisingly that has left them with anxiety about desferal. So from a psychological perspective, usually it's given subcut, but it can be given IV. You can give it anywhere from 8 to 24 hours, sometimes 5 to 6 days a week, but some people don't need that much to keep their iron well controlled. And you can start at a relatively young age, or if the ferritin's over 1,000. So desferal's, because it's the longest one that's been around, that's the one we've got most information about. The second chelator is deferriprone, or L1, and that's a tablet, and you can take that. Problem with that is that you have to take it in 3 divided doses, which can lead to issues with concordance. And there's deferasirox, or Xjade, which is now a film-coated tablet. There have been other trial compounds such as minihepsins, but in the UK there's nothing else that's licensed currently. So what are the potential issues with desferrioxamine? Certainly historically, when we used to use very high doses in patients when we're starting out using desferal, patients can become deaf. There's also visual disturbances, and those two are why we do the annual checks for ERG and audiology for our patients. There's an increased risk of Yersinia and Klebsiella infections, although those are also increased prevalence in people who are significantly iron overloaded. Some people can get significant local reactions, and if that occurs, you should consider putting hydrocortisone in the pumps. And our current issue is the slow running or fast running pumps and needle issues that are significantly impacting our patients. If anyone on the call is having issues with their pumps, do escalate to and let UKTS know, because they're trying to compile information on this at present. To try and avoid side effects, you can calculate a toxicity score. So you calculate the daily dose in milligrams, and then you divide by the ferritin and divide by the patient's weight. And this is for subcut desferal. You want to aim for less than 0.025. So this is a patient with the old school pumps that we don't have anymore, sadly. And you can also see this patient's got a port. But if you can imagine, these patients already have quite a significant burden of clinical interaction, having to come once or twice every sort of 2 to 4 weeks to the hospital for their transfusions. And then, even then when they're feeling well, having to hook themselves up to an infuser can be a significant challenge. So deferriprone, as I said, was the first oral agent. The thing that most people worry about is the unpredictable neutropenia. And so theoretically, you meant to monitor patients weekly for, well, theoretically forever, but certainly for the start of treatment. I would say that in my experience, most patients, if they're going to become neutropenic, they do it in the first 6 months. But I'll leave Emma to comment on that later. You can, as I said, it's in 3 divided doses. I think it's very good for getting cardiac iron out and maintenance, but it's not necessarily great in the majority of patients as a single agent for removal of liver iron. But you can, as you'll see, sometimes you need to be a bit imaginative with your chelation solutions. Deferasirox, the main problem used to be GI upset with the soluble form. It still does occur, but I'd say to a lesser extent. Renal toxicity is probably the most common thing that we see. And so especially when people are getting pretty well de-ironed, it's worth keeping a good close eye on their creatinines because they can start to climb up, and caution in people who have underlying renal disease as well, as we'll hear more about later. Eye and ear checks, are they still necessary? They're still in the SPC, which is irritating, and some patients do get a quite dramatic rash when they first start on Exjade. We can now, there's a whole variety of different combination regimes now approved, but allegedly a blue tech form is needed, although there are ways around that. Emma, over to you.
Okay, well, the first case study we're looking at is pregnancy with iron and the outcomes there. This is a 36-year-old lady. She came to us from Delhi in India, probably about 10 years ago. When she came to us, her iron levels were well controlled, but we do know historically that she has had in the past quite high ferritins. So we assume that she has previously had significant iron somewhere, most likely liver, possibly cardiac iron. 2 years prior, in 2019, her and her husband decided they wanted to start a family. Despite no evidence of hypogonadism, she had normal FSH, LH, and estradiol levels and was not obviously requiring any hormone replacement. Despite this, and despite actively trying, no pregnancy. So she was referred for assisted conception. Her partner had a normal semen count, so there's no issues on that side. Obviously, partner had been tested for thalassaemia and has no trait. So referred for IVF. Prior to this, obviously, we did all the pre-pregnancy checks. We had plenty of time, all planned nicely. Her liver iron was below 3, so she was perfectly, de-ironed, well chelated. No cardiac iron, and her echocardiogram in 2019 was normal. Volumes, ejection fraction, and no evidence of diabetes, all ready for the pregnancy, so nicely planned. A successful pregnancy. Now, what was interesting that even though this is a quite small girl with a relatively low transfusion burden, even during the pregnancy, she did load her iron very, very quickly, and it rose up to 17.4 milligrams during the pregnancy from previously around 2 point something. Fortunately, no cardiac iron was loaded, and her volumes and heart function remained normal, so very reassuring. She was, because of this liver iron loading, and obviously the potential that this could spill out into the heart and possibly cause cardiac impairment, it was decided to give her low-dose desferrioxamine in the 3rd trimester. This is quite safe in the end of the 2nd and the 3rd trimester. Not is contraindicated in the beginning of the pregnancy, particularly up to about 20 weeks, because desferrioxamine will interfere in the fetal skeletal growth development. So, but quite safe in the 3rd trimester at a low dose. So she was taking, I think this girl was taking 1 grams 12 hourly overnight for about 5 nights a week. Didn't particularly bring the liver iron down, but prevented it from escalating to higher. Ferritin was remaining around the 4,000, 5,000 mark, which is comparable with this level of iron. No issues with the delivery, and then breastfed for 6 months. Continuing with subcutaneous desferrioxamine, but now at a higher level because obviously the baby was out. Back on, once she had stopped breastfeeding, then it's safe obviously to put her back on to deferrazirox. During breastfeeding, we do not recommend oral chelators because they will be absorbed by the baby. The desferrioxamine is absorbed by the baby, but it isn't actually absorbed in the gut, if you like. So once stop breastfeeding after 6 months, back onto her oral chelator. Next slide, Em. Emma, can you do the next slide?
Oh, has it not?
There we go.
Got the next slide.
You got it. Okay. So then what happened in early 2022, spontaneous unplanned pregnancy, which again is quite remarkable because she needed assisted conception with the first pregnancy. This was not planned. We have seen this before, and we've also seen it in some of our male thalassaemia patients where they've needed spermatogenesis for the first baby, but then have gone on 2, 3, 4, 5 years later to naturally conceive. So as it was unplanned, she was still taking her deferrazerox, her liver iron, because we do think she probably was not particularly concordant. A young mother with a small child, probably not taking her deferrazerox daily as she should have been, and the liver iron had climbed up to 23.6 milligrams. So this is not an ideal place to start the pregnancy. Fortunately, although there'd be a slight decline, her cardiac iron levels were good. So this is where we look at what would be your concerns if this lady presented in your clinic with a high liver iron. She's been taking deferrazerox, spontaneously pregnant. Questions: what are your concerns? Should she continue with the pregnancy? And what are the issues that we need to think about going forward with this lady? So any ideas on this? Should we come back to that?
Sorry, this is Noemi. Not that I have the answer, just to provide some voice to feedback. I guess it's very hard to say you shouldn't continue with the pregnancy,
Yeah.
but we're concerned about cardiac iron and how she's going to manage with the pregnancy as it goes forward, and we're probably going to want to continue chelation, but then we are worried about the effect that the chelation is going to have on the fetus.
Absolutely, absolutely. So there are concerns. Obviously, she has a high liver iron, and at this stage, no cardiac iron. But again, we know that she loaded iron very quickly in the first pregnancy, so we're looking probably at quite significant liver iron towards the end of the pregnancy, which could very well spill out into the heart. Should she continue with the pregnancy? This was a big issue with this girl and her family. Her father moved over from India temporarily. The family were very concerned because their experience in India had been quite negative. Obviously, they have seen quite early deaths, and I do believe that they had some sort of knowledge of some poor pregnancy outcomes in the thalassaemia group there. So Dad was very against this lady continuing the pregnancy. So yes, lots of issues to think about. Also, there's the issue of diabetes. Pre-pregnancy, she's not diabetic, but obviously diabetes being a risk in pregnancy and with high liver iron. Next slide, please, Emma. So through the pregnancy, she chose to continue the pregnancy, and well, firstly, going back to the fact that she was on deferrazerox. We have seen this in quite a few of our patients actually who have become spontaneously pregnant, both on deferiprone and deferrazerox. Not ideal. Early pregnancy scan at 6 to 8 weeks to look to check that everything is okay, and we haven't seen any fetal abnormalities. So from that point of view, we're obviously very reassured, and we could reassure the patient. So we would not advise her at all to discontinue this pregnancy, though. Liver iron had obviously continued to climb. Recommended that we should always re-image sort of halfway through the pregnancy just to see where we are, particularly where the iron, if the iron is going into the heart, and whether she's going to need more supportive care there. Desferrioxamine was started shortly after. Should say that even though the liver iron was climbing, the T2 star remained normal, thankfully. Desferrioxamine started at about 22, 24 weeks at, again, a low dose of 20 milligrams per kilogram as a sort of maintenance therapy overnight. And her ferritins rose and remained for the rest of the pregnancy around 8,000. Fortunately, no complications though, no diabetes, no evidence of cardiac iron, no change in the cardiac function, and she gave birth to a healthy little baby girl just last week. Next slide, please. So the key learning points: transfusion-dependent thalassemia ladies we have known for many years can become pregnant in unplanned manner, even those who we may think are sort of peri-hypogonadal. You can chelate during pregnancy, and often this is required, but obviously should be discussed with the tertiary centre for recommendation on dosing and when to start. Very important to reassess iron loading at around 20 weeks. If there is evidence of any cardiac iron at this stage, or if it's unplanned pre-pregnancy, then a specialist cardiac review is essential during the pregnancy, and obviously advice on delivery as a result of that. All of these results, you can actually, there are the guidelines, an old green top guideline. The old thalassemia standards, but new ones updated will be out very soon. And the British Society of Haematology pregnancy guidelines are coming out very soon too. So all the information you need you can access from this. So is there any discussion topics going from this?
So Nandini has commented that they've had 2 pregnancies with liver irons of over 43. Both pregnancies were successful, and they both had their subcut desferol in the low dose in the second trimester. And the baby, both babies, or one of the babies was a bit small at birth, and obviously they were petrified and worried throughout.
Very worried. Hello, both Emmas, and hi, Bernadette. We've talked. We've been in discussion, but it's very good. We've been very worried with ours as well. But the question I have is about 20-week reassessing. Do you all do a liver iron, or do you do MRI scans?
Yes.
Yeah.
Our radiologists have been a bit more reluctant about scanning women in pregnancy. I haven't got a clue why.
Yeah.
The cardiac side of it can be a bit claustrophobic for some women. So my patient declined the cardiac, but we got cardiology with obstetric cardiologists who sees these patients. But do you do both cardiac and liver?
Yeah, do cardiac and liver MRIs. And if your TT star doesn't provide you with a left ventricular ejection fraction, then do an echo as well, so you've got that. And the other thing that we do, even in ladies who are, don't really have much iron on board during pregnancy, is to give them some desferal during the actual delivery as well.
Yeah.
Just because labour can cause like a big release of non-transferrin bound iron, and some patients there's cases historically of patients getting subcardiogenic shock during labour from that. So we tend to, certainly our practice at the Whittington is that we give desferal to cover that.
Yes, we do the same as well, Emma, just once they go into labour, onset of labour. The most recent patient we had was absolutely no iron at pregnancy. It was a assisted conception, went through pregnancy, and after delivery her LIC was close to 20. So they do iron load quite quickly.
Can load quickly. Yeah.
Nandini, did your ladies have cardiac iron, as I just asked? Or
no, they were all liver. Thankfully, nobody had cardiac iron.
Yeah. What we found is if people have had historic cardiac iron, then they're more likely to then reload in their heart for some reason. Yeah.
And just a question for me, sorry. So you said they were a bit small, and is that related to iron status, or is that more because of the anemia? Like, is there any? Do we know?
No, but the obstetrician were convinced that severe iron loading, the LFTs were slightly off getting towards the end of pregnancy, and both the babies with the moms with quite severe liver iron, the babies were on the 25th. They were growing well, but they were very, very small. I don't know, Noemi, with the rare anemia patients, do you find that sometimes, do you get this with small babies?
Not that I've seen, but I've not seen many pregnancies in the rare anemia patients.
No.
There's one bizarre family where the anemia gets better during pregnancy, which I have no idea why. Maybe a hormonal thing. Maybe we should be giving progesterone to the patients. But yeah, I'm not aware about that there's a direct link with the smoker days. But that's the whole point of this is, each of us will have seen a handful, and we really need to put all of these people together in one big registry and have a look at the data all together.
Brilliant. Thanks very much, everyone. So on to case 2. So this is a lady that I see in clinic at the Whittington. She's 49 years old now and has the classical sequelae of historical iron overload. She's hypothyroid, she's got hypoparathyroidism, she had primary amenorrhea and is on HRT. She's diabetic, insulin treated, and also has significant renal impairment due to diabetes. She it's a bit echoey. Let me find out who that's. If it's not me, can you mute? Is that all right? Perfect. She has had, unsurprisingly, given that history, previous significant cardiac iron loading, but in 2017, her iron was very well controlled with an LIC of 4.2 and a TT star of 32 milliseconds. Unfortunately, she developed some neurological symptoms on deferoprone and desferal combination, and was found to have bilateral optic neuritis with central demyelination, and was given a diagnosis of multiple sclerosis, but fortunately these things resolved. She then had a good period of stability from an iron perspective from about 2017 to 2020, but then her ferritin started to creep up during the sort of pandemic times, and part of that possibly was due to pandemic-itis, but also because her mum was sort of end of life, and there was quite a lot of conflicting priorities going on with her at that stage. So her LIC went up to 6.9, but TT star was still very good. She'd stopped the deferoprone, it turned out, due to headaches, and so we increased her desferrioxamine to 1.5 grams 3 times a week. She's a very small stature lady who's only not on large transfusion volumes at all. She'd be a patient who'd really benefit from luspatercept if it ever emerges from the cave into which it has gone to dwell. Deferoprone, we restarted at a low dose, and we also added in a third agent, XJade, to try and bring that liver iron down because the trajectory was significantly up. Then she developed ERG, had her on a routine ERG, showed changes potentially due to the desferal. So my question is, what would people do now? She's got renal impairment. Creatinine's about 125 to 140. GFR's about 30 to 40. Has anyone ever had a patient with ERG changes?
Hi, Emma, it's Nardini. Yes.
Hi.
One patient in 60s, she had rod and con changes. I reduced her dose and repeated the ophthalmology repeated it after, I think, 3 or 6 months or so, and it improved. We just had to reduce the dose quite significantly. But very similar. Maybe her liver iron was a bit lower than this, I think 4 or 5, but we persevered with the desferal, but we just got it lower, and it seemed to have worked for her. Your lady doesn't have visual symptoms, does she?
Well, she's got this sort of it's slightly difficult because of the MS and the optic neuritis. So she's got poor vision anyway, and she's got bad vision for a variety of different reasons. So it's a bit complicated with her.
My patient absolutely had no symptoms.
Yeah.
Only picked up on ERG quite significant changes, but as soon as we reduced the dose and it was repeated, it all improved. And ophthalmology, we are very convinced it's all due to Desferal.
Yeah, because she's got diabetic eye changes as well. So
that's
she's
very hard.
she's like
Yours is very hard.
Yeah. So because I've never seen, and I spoke to Farah Shah and Prof Porter about this, because they'd never seen eye changes in someone who's got as much iron on board as she had. It usually, apparently, it tends to be high dose and patients who their therapeutic index is high. So that was, so what did we do? So we did actually reduce the Desferal, and the ferritin continued. We actually stopped the Desferal. Ferritin continued to climb. We also thought about how we could try and reduce her transfusion requirements, and so I wrote to NICE about luspatercept. She wrote to NICE about luspatercept. I wrote to, what was it then, Celgene about luspatercept, then BMS about luspatercept. Unfortunately, her renal function precludes her from the clinical trials at the moment. And so in the end, I put her on hydroxyurea out of like desperado. And I actually did get permission from our medicines committee at the WIT to try thalidomide if things didn't improve. Then we thought, how can we optimize chelation? So this woman, even though she's not massively iron overloaded, is now on 3 agents because of her other complications from her thalassaemia. And I think this is potentially something we're going to increasingly see. We're repeating the ERG again, and we're looking for other, things that we can try and do about the renal function. So like actively supporting that and actively involving renal, monitoring closely to make sure she doesn't get stones, new stone formation that will, further impact her kidneys, and keeping a tight rein on her diabetes that I have to say she's very good at. So I'd say chelation in older patients, it can be complex and complicated by like multiple different issues. And also, if you imagine this lady, so she's now under hematology for her thalassaemia, with the routine transfusion appointments, and like myself and Emma P sort of fiddling forever at each transfusion with her chelators. She's under neuro for her MS, she's under diabetes, she's under renal, and she's also under ophthalmology, 2 kinds. So it's a big sort of burden. Did I say endocrine? I can't remember. So she's she's on, this is multiple sort of appointments and a big burden for this lady. So just to highlight that as an that sometimes you can't just give one agent and you have to use multiple, even in a very compliant patient, which she is. Any questions or comments for me from that?
Emma, I just want to ask for eye changes. We've sort of got on our list of things to do that all of our Thalassaemia patients should be having annual eye and audiology tests. Is that necessary? No.
So I do it a baseline, and then if they get new changes.
Okay.
Yeah.
Fine, thank you.
However, that is against the SPC. But
no,
but it's just like, for me, I just think you've got to be realistic about it, and and there's no, we've been using it for a long time now, and there certainly haven't been, vast numbers of reports coming through, and we're using it, in a whole variety of different patients now. And what are they meant to have? Are they meant to have, you can get someone to look at the back of their retina, but unless we're not doing ERGs on all these patients.
No, exactly.
So it's just pointless.
Yeah, thank you.
That's my But unfortunately, it's still in the damn guideline anyway. That's
Assad has just asked about ERG. Is it universally available?
yeah,
specialist centres.
It's scantily available. So I was looking at this. So in London, Moorfields definitely do it. But I was trying. I think Cambridge possibly do it.
Great Ormond Street do it for kids.
Great Ormond Street do it for kids. Anyone anywhere else? No, Amy? Do you in Oxford? Do you have ERG?
I think we can do it.
Yeah, it's you know, it does involve as well the patient travelling, which is, you know, as we know, leads to challenges with people attending if they have to, you know, schlep halfway across the country to attend an appointment. So it's, yeah, but it's not a universally available test, because I was looking into this the other day.
But is it standard?
Standard for people on Desperal.
It is standard,
yeah.
So
for people
it's worth
on
investigating
Desperal.
your local area to see if there is anyone, and kind of plugging into a service.
Yeah, I think that ERG is very specialized within ophthalmology. Only a certain people can do and review the results. That's the other thing I've learned.
Yeah.
So not all ophthalmology units have this set up, because you need to be trained to be able to do this. This is another. I mean, in the north, we do have quite a bit of these issues. So
it's mad. They like stick stickers to your eye.
Yeah, it doesn't sound like a nice.
It doesn't sound like a nice test. One of my patients ended up with like a corneal abrasion after it, and has like developed like an unsurprising pathological hatred for ERG. So it's fortunately she's now on XJade, so that's problem solved. But it's you know, it is another sort of complication, as it were. Great. On to Chris.
Also, my one, I'm doing a pediatric example just to throw it in the mix. So thankfully, they don't tend to have as many problems or complications as the adults do. And as this was a young man, he's obviously not going to be pregnant or going into labour, so it's all good. So he is currently 10 years old. He has beta thalassaemia alongside G6PD deficiency. So when he was born, it was a little bit tricky because he had a sudden drop in his hemoglobin, and we weren't sure whether it's time to start transfusions or whether it's a G6PD, like hemolysis related incident, but it turned out to be a G6PD issue. So eventually he started his transfusion regimen at about 15 months of age. We did 1 or 2 before, but then he went for a while without one. Then we commenced it properly in June, the year that after he was born. Next slide. So thankfully, because of his age, we were able to hold off Chelation until he was about 2, which means he could have had the XJade or whatever brand we're using now, because obviously the brand is gone and we get it cheaper. So his ferritin was relatively well controlled initially. There wasn't really any problems. He was stable. It was all good. However, we became dose limited to 180 milligrams due to a rise in creatinine, and he developed a Fanconi syndrome, which was thought to be due to the XJade. He was sent to nephrologists. He was sent to Great Ormond Street, actually, to be reviewed and seen of that. And once we stopped the XJade, it disappeared. He was sort of back to normal. So after that, we decided, okay, we've got to move on to Desferal for him. So again, it was working relatively well. The ferritin was maintained for a good period of time. And this family aren't the kind of family where I doubt that they're doing it. I mean, he was a young man who, I mean, no child wants to have a needle come near them. They don't want to be connected to something when you're sleeping. They'll be pulling at it. We've got to think of ways to distract them till they're asleep. But for him, he was not wanting it, but he let you do it. He understood. However, the problem we had is that the family were reporting more and more faulty pumps in their deliveries from the company that makes it. Either they're not delivering the whole dose in the time period that it says, some of them just were not priming, some of them were going too quickly, And we noticed this change in his ferritin. So on the bottom left, you can see a little trend of what his ferritin was doing. So as you can see, it's just creeping up and up and up and up. And we decided to do a ferrous scan of him because he reached about 3,000 for his ferritin. His scan was actually right. His LIC was 4.9 with a hepatic T2 star of 7.6 with a cardiac T2 star of 35. So he was actually holding his own from that point of view, but we sort of ran out of places to go because if he was going to keep having these faulty pumps and having redeliveries and missing doses, he's just going to keep building up his ferritin and eventually it will store more and cause all of the later down the line issues. So what would you guys do at this point? Would you retrial XJade? Would you move on to another one? Would you do a second line?
Do you do dual therapy?
It's hard to know. I mean, I'm not a pediatrician, so these kinds of things scare me, little people. But I guess I'd be keen to know the data on, you know, if you retry XJade, what's the chance of the renal problems coming back or making them worse, especially because with a child, you're, you know, sort of committing them to, if he gets ongoing renal damage, it's a different implication, isn't it, than if you've got an adult in their 50s, for example. So do we have data on that? I guess the answer is probably no.
No.
Yeah, okay.
However, to answer the question, we did re-challenge him. And again, it came back. So we've tried it a couple of times actually to get him back onto XJade, but it just wasn't working. He was leaking his phosphate, his creatinine was going up, and we just thought we can't put him through that again. So our decision after MDT was that he stays on Desferal. Next slide. And we added in interferoprone, which isn't ideal because obviously that's 3 times a day. As Emma said, it's more tablets to take. And when we first started it, he found it really painful, especially in his legs, because of all the iron that was getting pulled out. Again, we're a little bit, is he vitamin D deficient? But he wasn't. Is this just growing pains because he was sprouting up? And in the end, we were like, we need to keep trying because everything else is normal. And he was going on a holiday back to where his parents are from in Cyprus. And we were just like, take a holiday from it. It's fine. Don't take your Desferal, don't take your interferoprone. Enjoy that time. I don't want you being in pain when you're there. And when he came back and restarted it, we reduced the dose a little bit, and that solved all of the leg pain. So his ferritin is now downtrending, as you saw in that previous graph where it's going down a little bit. So hopefully we're on the right path now, and we can get him back onto Desferal as opposed to interferoprone. Then the key learning points, for those of you who haven't seen the pumps that we get, I don't know if these are nationally what you guys get. The Easy Flow, they're from Baxter, I believe. They're got a weird brand name as well. So they come in those little pressurized balloons and go in a plastic case. They're connected with a valve set, so with a needle into the legs or any subcutaneous tissue. And generally they work quite well, but for a while we had a period where loads of people were reporting problems with them and various issues. So the key learning points for him was that the pumps may not work. You know, it's not down to user error. Could be a production error, could be faulty pumps. And we've reported it, we've gone to UKTS, as Emma said, and we're trying to improve things, but we're a bit stuck because we're limited that we've only got one company that make it around here. And the fact that secondary chelators may be required in order to control the transfusion iron overload. We tried to avoid it. We desperately tried. You know, when you're just like, next transfusion, let's see what the ferritin's doing. Hope for the best. But for him, it didn't quite work. And because we couldn't try the XJade again, we just had to use interferoprone. Does anyone have any questions about him or his case? Like I said, it's not as complex.
So, Chris, there's no doubt that there's pump issues, but looking back at that graph from 2019 where the ferritin started increasing, the pumps didn't change that early on. So there was, and I know there was stop and start with the XJade and things like that. So yes, there was a pump issue. We know that, but what else was happening there to kind of kick that increase off, other than what you've already said? Because always believe that it's just the pumps. You know, we have a lot of there is issues with the pumps. There definitely is, but it wasn't back in 2019 because we had the old pumps then. So if they had a problem with those pumps and with these pumps, it's just I don't know. I don't have an answer.
It might be down to the fact that his age, he's rapidly growing, and we're giving him more and more blood because we're basically on his weight, aren't we? So we give 20 mils per kilo. So maybe we are just pumping him full of more iron through the units that we're transfusing. But yeah, here's an odd one. I think the consultant was a little bit worried about him, and we went through the MDTs locally to discuss how we all thought, well, how we should react and treat it. And I think it was left that we had no choice but to do the second line.
There's a question from Michelle. Sorry.
Would it be a completely ridiculous thing to go back to old-fashioned syringe drivers and ampules?
Not ridiculous.
The small pumps. So
yeah.
So the problem is, Emma P, do you want to comment on this? Because we there are a number of our patients who love them, who are still on this. I've got one patient, two who are still on their small pumps. But the problem is maintaining those pumps, Emma.
Yeah, definitely. I mean, there's a lovely I don't know if Chris and Bernadette, you remember the old Graysby pumps, which is what historically we used to use, and that's the two patients still using
syringe driver style pump.
The syringe driver,
like the little palliative care ones.
Yes, absolutely. Well, they're not commissioned now by the NHS, so there's no one to actually, check them, keep an eye on them, make sure they're working. We used to service them once a year. There's nobody. Our medical physics department refused to touch them because they're literally not, commissioned anymore. So that's a big issue, and it does worry me because if anything does go wrong with these pumps, fortunately these are adults, so they'll tolerate a little bit more if it does go a bit AWOL at night. There is, because as you were talking, Chris, I was thinking, why don't we actually think about going back to these pumps, temporarily if we can find them? There is an Italian pump that we've been looking at, Emma. I think you saw it recently, didn't you?
Oh my God! It was like the size of a horse.
No,
like,
no,
oh, different
not
one.
That one. No, there's
oh my God! I went
one.
to one which was like literally a, like a size of an infuser pump. It was.
Oh my gosh,
I've never seen anything like it. It was like this big. I was like, how am I going to tote that around?
Yeah, no, there is a much nicer one than that. Okay. It's probably about 2 inches. The problem is, again, we can get them, and I've talked to the medical physics department, but we can't get the syringes because they come from Italy. So again, it's all about that sort of thing. But it's a work in progress, and I do think that particularly for those patients who just have it overnight, then I think these small pumps may be appropriate for them, and they do deliver the dose as they're supposed to. But as we know, there's quite a few who are on it 24 hourly, and I'm not so sure it's going to be quite so having a whirring, noisy, quite heavy pump attached to them. So and the other thing is, if you remember back the old days, that we used to get a lot more abscesses because the patients are responsible for actually mixing them up, and they're not doing it in a aseptic technique, and they're not necessarily doing it sometimes even in a relatively clean way. So that, there's pros and cons, but I think it may be in the case of that child with proper parent and the patient education, he's using it overnight, then there would be a place for that.
Yeah, I think they would do it as well.
Yeah, and they would do it.
We've got our adult patients asking for them, like they've still got one they've broken, they're asking for a replacement. It's like, well, we can't, unfortunately.
Emma, can you share the details of the Italian pump? Because I've got a patient.
I'll forward that on to you. Yeah.
I've just got a question from Grace about emotional stress affecting iron chelation and kind of the impact. And I think we can all agree that that's a huge impact.
Yeah,
on all treatments, let alone iron chelation.
Because they're just not going to. It's all about prioritization, and if there's other things going on in their lives that are stressful or, even fun, sometimes, it's not necessarily going to be their priority to take their chelation. What I'd say is then you end up in a situation like so we've got quite an older cohort, particularly at the Whittington, and a lot of our patients now, most of their problems are due to their diabetes that's secondary to their previous iron loading, or problems, they've got AF because they're now de-ironed from a cardiac perspective, but they had significant cardiac iron before. Or their bones are terrible because they've been hypogonadal for yonkers, and also potentially historic effects, with the growth plate issues around high dose desferal when they're in the growing phase. So it's it's difficult though, because I remember when I was a teenager and look at my daughter who's 13, it's like good luck. Convincing, because you think you're immortal then, or even in my 20s, and now I'm 45, old lady. It's then you realise the potential sequelae of being less concordant, shall we say.
Yeah, I've got some adolescents at the moment where the parents are struggling to let them have their own independence with their conditioning, managing their condition, and some who are trying even younger. And Grace, I know you know these ones as well. They used to hide their XJs in the microwave and tell mum they were taking it. It's tricky because they don't, like you say, they think they're invincible. They don't see that later down the line they could have all these extra issues. They just care about the here and now.
So Nandini's just commented, sorry, cut you off, Chris, about making it a habit, and this is something that we quite often say as well. So you make it a daily activity. So when you brush your teeth, you take your XJ, associate it with something that you do every day, and train that from a young habit. Although I'm very bad at brushing my 1-year-old's teeth, so it would fail on the get-go for me. But yeah.
One thing I've done for one of my teenagers who's sickle, not foul, and it's not chelation, but hey, it's a once-a-day medication, that most teenagers now seem to have a smartphone, especially with like iPhones. There's this new setting in the health app that is a daily medication reminder where they get to mark every day that they've done it. And he seemed to react quite nicely to that. And we set that up the other day and showing him how to use it. So I think that might be the way forward for the older ones. But yeah, for the younger ones, we always say like leave the box by the toothbrushes or something like that. But yeah, I don't know. That's still challenging to get them to swallow it.
That's how I got my brother to comply with his Becotide inhaler, was by putting it by his toothbrush, because then he could brush his teeth afterwards. So because he wasn't taking it because he got mouth ulcers, I was like, well, brush your teeth after you've taken it and then it'll be all right. So, yeah, there's all sorts of techniques, but I've never had a patient who's 100. Emma, have you had a patient who's been 100% perfect 100% of the time?
Who is? There's
you're on mute.
We have the one who still uses the old pump. I think she's the
only one. She is.
Yeah, but she's moving into toxicity level, so it's a bit of But on the whole, absolutely not. It's impossible. And with life changes, people moving away to go to university, everything changes. There's so many different phases in our life, isn't there, that's going to affect chelation.
And I just think, Emma, back to that, your case study, all the different appointments she has to manage, and then you add in the medication, and then a job, and then children, and then you're not going to prioritize taking this tablet most of the time, even though you need to. Life is happening with or without you, so you've got to kind of carry on.
Yeah, it's the mental load, I think, can be like massive, and it's that I think is a significant thing.
And it's not as if you don't take it, you're not going to feel crap, are you? It's going to be later down the line that if you're not taking it regularly, you'll notice these differences.
Yeah. I've Emma, in your kind of scenario with your pregnant lady, just thinking, I've always kind of come up with quite a lot of resistance from the patient side when you say, oh, we need to do a scan at 20 weeks or reintroduce some chelation at this time or delivery, and there's always quite a lot of reluctance to obviously do medical interventions during a pregnancy, and I just wondered if anybody had any kind of magical ideas or kind of thoughts about that, and how to combat that just in general.
I have to say I haven't seen much. No, I have to say it's quite the opposite in our cohort. They tend to be pushing, particularly in the case that we presented. You know, actually pushing for things that perhaps when you know. I don't. It's interesting.
Yeah, I think it's the what's the norm in the thing. So if they come to I think it slightly depends on the way the service is set up as well. So because all our patients, it's only red cell patients on the units, and so they're all in together and they all talk, which causes problems sometimes, or challenges, let's put it that way. But actually, if that's what they're all having, then it's normal for them, and so therefore the way we do it at the Whittington is we also see all our patients once a month with a haematologist and an obstetrician in the same room, and so we push that. And also even pre-conception with our ladies, I will speak to them, that this is why we need to de-iron, and then that we will recommend re-imaging, and we if the levels are too high, it's a risk of you going into heart failure, which is going to impact on the baby, etc., etc. So I try and do as much of the prep work pre them
I think that's
in the first place.
The pre-pregnancy.
Yeah, well, because once you're pregnant, you go a bit like loon. So it's do you know what I mean? And so I can totally see if it's like total, they haven't been pre-warned, they're not going to take it well.
Trying to say I was crazy, Emma?
No, there's always a risk. I decided I was going to sit my part 1 FRC path with a 6-week-old child, so I think I clearly was a bit bonkers.
Okay, are there any more questions or comments or anything to share?
Really great cases. Thank you so much.
Brilliant.
It's really fun to do it like this.
Yeah. Well, thank you very much, everyone, for coming. And
thank you.
We'll be seeing you all in a variety of different contexts.